aspect of surgical treatment of cancer. And we'd like to open the floor for questions and discussion. So if there is any question from the floor. Maybe I would like to start with a question to my very good friend and colleague, Dr. Omar Youssef, about radiotherapy and its use after implant surgery. Can we conclude out of the studies that you presented to us that any tumor that is node positive or that is larger than 3 or 4 centimeters should not be considered for skin sparing and implant reconstruction, since it necessarily would receive post-operative radiotherapy?
Thank you for your question.
Well, keep the light on, please. افتح النور من فضلك.
It's very difficult to answer this question. We have to agree that any patient has the right to have immediate reconstruction, whether she's going to receive post-operative radiotherapy or no, and this depends on your counseling with your patient. We know that for locally advanced breast cancer, and this is very well known, which is stage 2B or higher, it is better to postpone the reconstruction until the end of adjuvant treatment. At the same time, we have to admit that after looking into the literature, and especially after these systematic reviews and meta-analyses, there is no significant difference whether the patient is going to have radiotherapy before or after reconstruction. So it is still a safe procedure, but you have to explain to the patient that she will have higher incidence of complications that will alter a little bit the cosmetic outcome. If she prefers to postpone the reconstruction, so it all depends on your decision or your counsel. The most important point that I would like to show here that now there are new indications for post-operative radiotherapy. Now, for the patients with 1 to 3 positive lymph nodes, in the past we used not to irradiate them. Now these are in the group of patients to receive radiotherapy with some criteria like the lymphovascular invasion or matted lymph nodes or advanced disease. So we have to put this into consideration and maybe to be wiser to postpone the reconstruction.
I'd like to make a comment on the post-mastectomy radiation in 1 to 3 positive node. And I think you, Omar, presented very nicely that paper, which is a meta-analysis. The problem of that meta-analysis, that the study is driven by 2 major studies that showed a significant improvement in survival with radiation therapy. And when you look at the local regional recurrence in those studies, there's a 27% local regional recurrence after mastectomy. If you are a surgeon and you're getting 27% local regional recurrence, you'd better retire. Most of these recurrences were in the axilla, and the reason behind that is because the number of nodes that were taken were 6. Now, they have realized that this was a problem, and they reanalyzed their data, and they found that even when you have 8 or more nodes, you still have an improvement in survival. Having said that, when we do a sentinel node biopsy, sometimes we get 8 nodes in a very small tissue, and we know we have not dissected the axilla. Because we were questioning the value of that data, we reviewed our patient at Sloan Kettering, and we have 1,300 patients who had a mastectomy, had 1 to 3 positive node, and we looked at those who received radiation versus those who did not receive radiation. We had 950 patients who did not receive radiation with 1 to 3 positive node. The local regional recurrence in these patients with the 7-year follow-up is 5%. How much are you going to improve the survival in these patients if your local regional recurrence is 5%? So yes, when you look at meta-analysis, I strongly urge you to look at the fine print and look at the number, and make sure if it makes sense or not. This is why we're not recommending radiation in every patient who are 1 to 3 positive no. Now, we looked at the multivariate analysis. What are the predictors of local regional recurrence after mastectomy? We found 2 predictors. One is a young age, younger than 50 years of age, and 2 is a lymphovascular invasion. And particularly when you have those 2 factors combined in a patient, the risk of local regional recurrence is above 10%, then we would definitely recommend radiation therapy. So at this time, we're not radiating every patient at Sloan Kettering who is 1 to 3 positive no, and we usually reconstruct these patients. And I would urge you to review the data with a lot of grain of salt.
If I may add, I totally agree with all what you said, and this is one of the problems of this meta-analysis. It did not go into details, and it excluded so many studies. However, it showed their results. Again, it did not answer the crucial question, the gray zone, those patients with 1 to 3 lymph nodes. What should we do for them? And I believe in most of the institutions, still, it is a problem. In my institution, we had a meeting last week, and there is a consensus that started in 2013 that patients with 1 to 3 lymph nodes, young age, with lymphovascular invasion, high grade, these are the only indications for them to be irradiated.
I have a question for Dr. Rainsbury. So, first, 2 questions. The first one, lipofilling. Can we do the lipofilling immediately after, while you're doing the lumpectomy, or you have to wait for the patient to have radiation and then you'll do the lipofilling? And the second question, did I understand correctly that in your algorithm, when you have a positive margin and a positive node, the patient would need a mastectomy?
Perhaps I'll take this in reverse. The situation where you have a positive margin and a positive node, there are indications when you go back and re-excise. It depends on the extent of margin positivity and how much you've already taken away. Because by that stage, you have decided on the volume of replacement. You can't increase it. You could by lipofilling eventually. I'm sure these things will kind of change that. So, yes, generally in that setting, you would consider a mastectomy as a discussion with the patient. You can go, in fact, I think about 7 or 8% of our patients who've gone back and taken a look. The default option is no, you can't go back to mastectomy. The number of patients you have to do that is extremely small if you use intraocular actually. The first point you raised was about lipofilling. Now, this is becoming increasingly popular. We've actually steered away from it completely because I share some of the concerns that Shahid has expressed in the past from the oncological point of view, and I think the jury is out, and I prefer that other people find that out, either in the form of their personal experience or in the form of a trial. The second point to make is that if you've just injected stem cells into the region of your resection, and then you give them radiotherapy, and then you give them a host, I don't know how many of those cells are going to survive. We know that there's a volume loss of maybe up to 50 or 60% of injected fat. So it doesn't seem very satisfactory. It looks great to begin with. I think the jury is out.
So irrespective of the nodal positivity, if you have a positive margin, you cannot re-excise, then you take the patient for a mastectomy. So irrespective of the nodal positivity, whether the node positive or not, has nothing to do with the decision on mastectomy.
I think the only decision there is do you do an immediate reconstruction or not? And that comes back to our discussion about the involved, because there are many other factors that you mentioned and Omar mentioned. I mean, we use something called the Oxford Prognostic Index. So we put together these facts and come up with a score. And if the score is above a certain level, then we go ahead. So we try and objectivize it.
In all our patients where we do glandular displacement, we routinely take them back for re-excision because we document very accurately the way we close the cavity, and we have an idea where our margins are, and we tend to excise it. However, as Dr. Rainsbury said, when you do a major, or what we call is a extensive, dramatic rearrangement, then it may be difficult to know where to go back. although some people report putting clips at a specific site where they will do on the glandular part, because this is where you're going, and I find it difficult to find them back. You do, and then you put actually number of clips, and it's so confusing. So it is very difficult. We usually put 1 clip superior, 2 clips lateral, 3 clips inferior, and 4 clips lateral, but still it becomes very confusing. So some people have raised the possibility of putting a specific marker in the cavity, a little marker in the cavity that has a form and maintains a small shape in that cavity that would allow you to go back. I still find it very difficult when you do major resection.
Yes, I would agree with that. Just come back if you do a post-op mammography therapeutic mammoplasty, then you put your radiotherapy marking clips in. They're all over the place. So the question then is when you do your boost, if that patient needs a boost. I think one clever idea, and it will depend on how things look in the future, is if you could do your tumor resection first, do intraocular radiotherapy, and then you go ahead and do your therapeutic mammoplasty that gets over there. You're irradiating the balls exactly where they are. The other way around it is to put your clips on the muscle unit. But the problem with that is that your margins are still all over the place. The radial margins are everywhere, so it is a real problem.
Can I ask a question to? No, go ahead. It's only related to this margin thing. I just want a very specific definition by Dr. Rainsbury. What is the acceptable negative or acceptable satisfactory margin today, 2015?
I won't liken you to Homer Simpson, but we were talking about it this morning. You may not have been here at the time, but there is no international consensus, Sharif. The problem is that we now have the consensus statement from the SSO, Astro consensus statement from last year, which is tumour not touching ink for both DCIS and invasive carcinoma. Am I incorrect in that? Would you like to just...
The consensus relates only to invasive cancer. They may have DCIS on the margin, but they have invasive. The consensus for the DCIS, pure DCIS, is in the work. It didn't come out yet.
Right, because I read that paper quite carefully, and there were 1 or 2 references to it, but I assumed when I read the summary that they were including both. I'm interested here, because if you look at the other guidelines around the world, it's 2 millimeters for DCIS. That's the majority of you at the moment. And tumour not at the margin for invasive carcinoma, but with often not stated. In the UK at the moment it's 2 millimeters, but I think everyone's getting smaller and smaller and smaller as time goes by.
And do you think doing a frozen section during surgery would reduce the number of re-excisions because of positive margin?
You missed the session this morning.
Yeah, the answer is yes, it does. There's lots of information and several studies showing that it does. One from the
but one that we talked about this morning from the Mayo Clinic. There are 2 or 3 other quite big ones. A couple from Japan. Our own experience is the same. But you have to have the setup to do it, and you have to have pathologists who will fall into line and do it for you. And you have to accept the limitations of the technique. It is unreliable if you're looking after neoadjuvant chemotherapy, if you're looking for margins in invasive lobular carcinoma, and in people who have certainly intermediate or low-grade DCIs. It's very difficult to make a call on those.
Professor Petit?
Just a comment about the question of Mahmoud about the indication of lipofilling, immediate lipofilling after conservative treatment. Obviously, this would be very interesting to do that. And it has been done, it is done now, and there is a publication, I think, which just occurred a few months ago, coming from Brazil. They start to do that with among, I think, 100 cases with very good results. The problem is that there is such a discrepancy between the results of the research on one side, on the animal